Good afternoon, and welcome to today's Tuesday topics, the liver and the kidney and hepatic renal syndrome. How common is it? How should we recognize it? And what can we do about it? So excuse me while I share my screen. Start right off right now. Oops. Okay. So really, this is about hepatorenal syndrome or hepatorenal encephalopathy, often very common to see the two together. And our main case is a case that was in our emergency department and moved to the medical ICU. But I have two other short cases. Those are from the literature to just actually elevate the points of what I'm looking at with our patient. So really important to remember that HRS, hepatorenal syndrome, is the name of the syndrome that is the correlated response that we often see with patients who have advanced cirrhotic liver disease. Sometimes we can see it with metastatic tumors. Sometimes we can see it just with portal hypertension, but not necessarily chronic cirrhotic disease. But in general, it's a primary chronic cirrhotic disease state. So the problem, of course, is that when we have patients who don't really present with chronic cirrhosis, who may actually just have portal hypertension and ascites, we can also see these patients develop a very acute kidney injury. And there is a very narrow window of opportunity for protection for these patients, for intervention for these patients, and for shifting the trajectory to death. And that would be in both types of HRS. So first of all, if we just take a quick look at the pathogenesis. So either portal hypertension alone or portal hypertension plus liver failure, we understand, as many of us have seen these patients time and time again, that a huge amount of volume is in the abdominal vault. That's the volume that we call ascites. So the patient themselves are centrally, profoundly hypovolemic. But the products that are released when the liver is under-resuscitated, under-perfused, or in chronic liver failure, the products that are released promote a very significant arterial vasodilation. Now, combining that arterial vasodilation, which makes the patient look like they have septic shock, with central hypovolemia, obviously causes two very important factors. One is now we have a reduction in effective arterial blood pressure and blood volume, and a significant reduction in the cardiac output, really the stroke volume of the patient. So what ends up happening is a secondary and very, very profound renal hypoperfusion, and in particular related to initially to this arterial dilation. Now, eventually you'll have arterial constriction, but in the beginning, you have arterial vasodilation. And as we see kind of this reduction in the cardiac output and the effective arterial blood pressure, what happens is that the kidney will start to reabsorb more salt and therefore more water. Okay, so what you see in those patients is they're reabsorbing a lot of water, they're reabsorbing some salt, but the salt in relationship to the water, it looks like the sodium is relatively low. So they're going to look like a patient who has heart failure with a mild to moderately low sodium and a high volume overload. Okay, now what we're going to do is correlate these two things, evidence of liver dysfunction and evidence of renal dysfunction. And the renal dysfunction is primarily caused by the uncontrolled liver dysfunction. Hence, we call it the hepatorenal syndrome. So whoever knew about this club? I don't want to join this club. I don't think I'd like to be a member. This is the International Ascites Club. So these are diagnostic criteria actually produced by them to help us look at patients and make good diagnosis for hepatorenal syndrome. And this is their basic diagnostic criteria. Hasn't really changed much. I'll look for the most updated version. This is the most updated that I could find. It's actually about 8 years old, but there wasn't anything in the literature that I could see as a further update. But of course, very first, chronic or acute liver disease with severe hepatic insufficiency, and that most important point, portal hypertension. Now, that's associated with this secondary renal dysfunction with a very low GFR. You get that back on your chemistry, and a serum creatinine that is significantly elevated. And this is urine creatinine collection, 24 hours, which we rarely do anymore. We really just look at serum creatinine and GFR. Now, the patient doesn't actually have shock. They don't have signs of shock. Their blood pressure may be low, but it's not extraordinarily low. And they must be evaluated for bacterial infection. No sign of bacterial infection, absence of shock, and they have not had any nephrotoxic agents recently. So, of course, many of our agents, vancomycin, gentamicin, are renally toxic agents. So really, this early diagnosis almost always occurs in the emergency department. It's much harder to diagnose it in-house. Patients already received a lot of antibiotics. That might make it a little different. But what you actually see is that you cannot improve renal function. So remember that what we're going to do to test the kidney in this case, what we're going to do is give some volume and we're going to give diuretics, but the patient cannot maintain an improvement in their renal function. In other words, their creatinine may decrease, but it'll go right back up and it will not be sustained. So unsustainable improvement in renal function. And then you have to look at that urine and say, is there protein in the urine, which indicates an intrinsic renal disorder? There's no excessive protein in the urine. And looking at an ultrasound, we are not diagnosing that the patient has some kind of obstruction. Okay, so let me clear this back up again. 3 forms of acute kidney injury: pre-renal, intrarenal, postrenal. Pre-renal means poor blood flow and poor volume going to the kidneys, so filtration doesn't take place. That's what we're going to say right now. That's what we're saying here, okay? But if the problem is pre-renal and I resuscitate you with volume, that should get better and stay better. If I give you volume and you get better momentarily, but then you actually get worse again, that means we've ruled that out. We've ruled out that it's the volume. We've ruled out that it's heart disease. Intrinsic renal failure most often is evaluated by proteinuria, by the loss of protein. Remember that the tubes of the kidneys have a very firm border, and when the border gets injured, as it does in intrinsic renal failure, protein and other substances are let across and then come out in the urine. So we've ruled that out because you don't have proteinuria. And then we use an ultrasound to assure that you're not actually occluding outflow of urine from the bladder. And of course, that's what's known as obstructive renal failure or post-renal failure. And that typically occurs in the intensive care unit. Can occur because you have renal stones, you have parenchymal disease, or you have a kinked Foley catheter. So we've ruled out all these kinds of things. And those criteria, those main criteria really do need to be there. So first you have a suspicion, and then you rule out shock, especially you rule out, intra-abdominal hypertension. You also rule out bacterial peritonitis, and you're really ruling out anything that might be occurring in the abdomen that is affecting kidney function. And then you give volume and you give diuretics to see if you can have some restoration of renal function. So some other criteria that can be applied. Okay, so let's see. Always have to remember when you join onto Zoom, you've got to mute yourself, but I've done it already, so no problem. Okay, so minor criteria, and these are helpful to us, is that you are actually oliguric. You're less than 500 mils per day, but one of the really important concepts when we're looking at kidney function is, are the barriers of the tubules of the kidney intact? When they're not intact, you're going to waste a lot of urinary sodium. So urinary sodium is less than 10 milliequivalents. Normal is 20 or less. Here, less than 10 milliequivalents, which ruled out that the barrier of the tubules was destroyed. And the urine osm is going to be greater than the plasma osm. Okay, so concentration of urine, concentration of plasma. Remember, we're always going to make comparison of urine and plasma osm. If plasma is concentrated, urine should be more concentrated. If plasma is dilute, urine should be more dilute. But here, urine osm is going to be greater than plasma osm. So in other words, you're not releasing fluid, you're maintaining the fluid, your plasma is dilute, but your urine is concentrated. Now, lots of times we look at that, and it's going to be really important because we're going to look at that patient. We're going to say, does he have heart failure? Yes or no? Does he have SIADH? Yes or no? So there are a lot of things that we're going to think about because the patient's going to be wet, but he's not making much urine, which is going to be of great concern to us. And that, of course, goes along with all different types of renal failure that you can see. So really important when we're correlating that. So now we just kind of bring that all together and say clinical features of hepatorenal syndrome. Number one, an increase in serum creatinine of greater than 0.3 milligrams above whatever their baseline was. Now, this is going to be really important when we're looking at our case study because we're not making this diagnosis in somebody who has had a creatinine of 5 and now it's 5.2, now it's back to 5.1, now it's 5.2. They're not having a significant increase above their baseline, and typically they don't have any indication of renal dysfunction. Now, there's two types of HRS. The first one, I would call it very acute. They've had a twofold increase or a rise to greater than 2.5 milligrams within the last 2 weeks. So that's assuming you have information. Gradual increase is either seen over a longer period of time or a little less severe rise. So he might have been first seen at 0.8, now he's 1.6, and then the next time you see him, it's 2.2, and it's been 3 months between each measure. That's a slower rise over a longer period of time. But one thing that is always present when we talk about HRS is the patient has severe liver disease. That you must always consider, severe liver disease. Now, again, most frequently we're going to talk about advanced cirrhosis or severe alcoholic hepatitis, but also patients who have portal hypertension, patients with severe fatty liver. And typically they're going to have moderate to severe ascites, which also means, my friends, you must consider intra-abdominal hypertension or intra-abdominal compartment syndrome when you're evaluating these patients. Probably not the best place to evaluate them in the ED. These types of questions really are the ED types of questions. But here's the thing. It's really important when you see a person with severe liver disease and moderate to severe ascites, despite the fact that their creatinine has gone up and that they are not making urine, they must get volume. So normally when we see someone who isn't making urine, whose creatinine is increased, we like to withhold volume. Here, they have to get volume because, of course, they are actually sufficiently arterially hypovolemic. The majority of their volume is in the abdominal vault in the ascites presentation. What's also most often, not always, this is always present, which makes it pretty straightforward. You have liver disease, you've got ascites, your serum creatinine went up, I'm going to give you volume, you made more urine or you didn't make more urine. Okay, that's it. It's pretty straightforward. Not a lot to remember. These are usually present, and that is that the urine on analysis is unremarkable. It's not filled with white cells. Patient doesn't have a UTI. But most importantly, there is no proteinuria. That is critical when we look at the urine and we're trying to diagnose HRS. Now that urine output is down and or they do not respond to diuretics, and the diuretic failure of response more commonly occurs with the patients who have had that slow decrease in renal function. You see typically with the type 1 HRS, when you give a diuretic, you typically are going to see a urine output response. It may not be sustained, and that they may go right back down to that elevated creatinine and the decreased urine output, which means we're going to have to think about some other things that we need to do for those patients. But here's the other thing. If you're interested in the kidney, you'll remember that the part of the tubules is to preserve sodium. So as long as your tubules are functional, you should be releasing less than 20, and most often less than 10 milliequivalents of sodium into your urine per day. Now, if you went out last night and you used a bottle of soy sauce with your sushi, you're probably going to have a higher urine sodium. But we're talking about now somebody that we're just trying to make an evaluation on. We might ask them questions about their diet in the last 12 hours, if they're able to answer. But typically what we're going to say, less than 10 milliequivalents of sodium. Now, all that does is measure how much sodium is being passed at the kidney. But this is the one that's really important. This is called fractional excretion of sodium. And it looks at serum sodium times urine creatinine and urine sodium times serum creatinine. Thank goodness we don't have to calculate it. All we have to remember is this: even if you were wasting a lot of sodium, as long as your FeNA, the fractional excretion of sodium, which is a calculation that looks at both serum and urine sodium, serum and urine creatinine, as long as that FeNA is less than 1%, we now are basically ruling out a secondary cause for renal dysfunction, not a direct cause, but a secondary cause, and that would be the liver. Okay, so the liver has caused this dysfunction. Out of the 3 types of abnormal function, I'm not talking about sustained organ dysfunction in the ICU, but on presentation in the ED, seeing a patient with an elevated serum creatinine, a decreased glomerular filtration, and a concern about liver disease. Out of the 3, true hepatic renal syndrome is the least likely. It's only about 13% of those patients. Bacterial peritonitis is the second most likely, and the most likely is intra-abdominal hypertension. Now that occurs because your patient has ascites. So if I've got anybody here who takes care of patients in the ED, you should consider how important it might be for you to be measuring abdominal hypertension in the patients who are presenting to you with ascites, because that can actually rule out perhaps compression of the renal arteries and renal dysfunction. So really, really important. Lots of different etiologies that cause acute kidney injury with advanced liver disease, right? And remember, this is acute kidney injury. So by the way, that means in general reversible. So first of all, volume depletion, right? They may have had a GI bleed. They may have been over diuresed. They may have diarrhea. They have volume in the extravascular compartment, but not inside the artery. That's the hepatorenal syndrome actually describes what we've just said. They may also have some tubular necrosis because they've got hyperinflammation and destruction of the renal tubules, as you can see with patients who also have nephrotoxic drugs. They may have some inflammation at the very gentle capillaries that are in the glomerulus, which is the filter of the kidney. That's the glomerular disease that can cause, of course, the renal dysfunction. And before, as I mentioned, abdominal compartment syndrome. So very important that I want to make sure you appreciate hepatorenal syndrome is a syndrome of discussion. We cannot diagnose it absolutely. You have to rule out other differentials. So really, really important to rule out differentials. You must have the absence of shock from any other cause before you can assume that you have hepatorenal syndrome. So really challenging when you're looking at somebody who's got pre-renal dysfunction, which is from poor cardiac output or poor intra-arterial volume or loss of vascular tone, or perhaps the patient's been over-diuresed, is really, really important to appreciate that the urine analysis will be unremarkable. So you don't have signs of infection exemplified in the UA. UTIs are a major cause of sepsis, so you can't have infection. Any signs of infection in your urinalysis of white cells, etc., and urine sodium excretion has to be low. So when you get your UA back, you'll have the urine sodium. You should also have a FeNA, or you might need a nephrologist to actually calculate for you. And here's what you're going to do. To really actually understand the difference, You're going to stop any diuresis, and you're going to challenge the patient with albumin, okay? So if the creatinine and the urine output improve when you stop the diuretics and you give fluid gels with albumin, this is an arterial or primary volume depletion. It could be from sepsis, it could be from other things. But if you're giving patient fluids with albumin, I'm going to give you some advice about the albumin. I'm also going to give you some advice about what's been recommended most recently for renal resuscitation and evaluation in just a few minutes. Really, really important. If creatinine does not start to come down and urine output doesn't go up after you've given a volume challenge with albumin, this is one time we're going to advocate for albumin, it's most likely hepatorenal syndrome. So basically, when we look at the clinical perspective, right, what we see first is we note the ascites, and we see that the patient has liver disease and portal hypertension. From there, we give diuretics, and the patient has diuretic refractory ascites. So they don't make any urine after we've given the diuretic. Now we're going to say this is most likely hepatorenal syndrome. Physiologically, you move from portal hypertension to splanchnic vasodilation. So what that means is actually in a backflash, those vasodilators are going to primarily affect the exciting vessels from the kidney, but we also are going to have the release of sympathetic stimulation, etc., that will cause renal vasoconstriction. So these two are opposed to each other, and what that ends up doing is causing actually distortion of the glomerulus and destruction of the very gentle lining of the glomerular filter, which then puts us into renal failure. Now, if we wanted to say particularly how do we look at a type 1 versus a type 2, type 1 remembers this is really acute. This happens quite acutely, usually under our eyes or in the last day. Their creatinine increases to greater than 2.5 milligrams per deciliter, okay? Or they've had a 50% decrease in creatinine clearance, and that occurs over a short period of time, usually less than 2 weeks. It progresses very, very rapidly, and there is a very poor short-term outcome. Unless we are in this patient's face, get them on CRT, get them on Mars, get them on a transplant list, give liver support, the probability is they're not going to survive. And 2 of the cases I'm going to look at here do not survive. Our case does not survive, one of the cases from the literature. The type 2 patient has an increase in serum creatinine, but it's not nearly as aggressive, right? And it's occurred over time. But the beauty of this, and the refractory ascites is usually present, meaning if you diurese, you try to diurese them, they won't diurese. They're much slower progress, but their prognosis is not as bad as type 1. So that more likely that we're going to have some resolution for those patients. They have more compensation capability than the type 1 patient. The type 1 goes down really fast. The type 2 goes down longitudinally a lot slower. Okay, so first we'll start with this case. This is not my case. This is a case from the literature. A 35-year-old man who has alcoholic cirrhosis, ascites, and a history of alcoholic hepatitis presents to ED for management of a cirrhosis, and he's diagnosed with new onset renal insufficiency. So immediately you say, aha, he meets a lot of criteria here. He hasn't ever had a renal dysfunction before. He doesn't have diabetes. He's had blood transfusions at another hospital 5 days before he suffered. 5 days before he came to us, and before he had suffered, he was admitted there. I'm sorry, because he had suffered a GI hemorrhage. No history of bacterial peritonitis, and no history of recent treatment with nephrotoxic drugs. So you can see most of this is all history. On admission, he's taken pentoxiflin, 400 milligrams 3 times a day for his alcoholic hepatitis, and furosemide, 80 milligrams a day, and spironolactone, aldactone, 200 milligrams QD for cirrhosis with ascites. So we're trying to control his alcoholic hepatitis here with pentoxiflin, and we're actually trying to promote diuresis with his furosemide and spironolactone. And of course, spironolactone is a potassium-sparing diuretic, aldactone. On physical examination, he has jaundice, ascites, and spider angiomas on his chest. This is all very, very common with somebody who has chronic liver failure. And his viral hepatitis serologies were negative, but the ultrasound showed that the liver had a lot of nodules and he had a very enlarged spleen. No evidence of any chronic renal parenchymal disease or any obstructive uropathy. And on his analysis fluid, it looked at the albumin concentration, which was greater than 1.1 gram per deciliter. So remember that one of the problems with ascites is the ascites fluid has a lot of albumin in it. That albumin pools more fluid, and more fluid, and more fluid. And now you have hypoalbuminemia in your serum. So they stopped giving diuretics and they started giving volume. And they replaced him with 1.5 liters of isotonic saline. That's fine to give LR, well, probably not to give LR, probably fine to give plasmolite, fine to give isotonic saline. He does have liver disease, so you always worry a little bit about his ability to conjugate lactate into bicarb, and that requires liver function. So the only time I ever say caution with LR is if the patient has liver disease. And they gave 120 grams, I'm sorry, of albumin over several doses. But his renal function continued to get worse and worse and worse. So the diagnosis here is, right, they gave him volume, they gave him albumin, but he didn't get any better. They gave him volume, they gave him albumin, but he didn't get any better. The volume and the albumin, of course, ended up in the ascites space, and that actually tells you that the diagnosis is hepatorenal syndrome. Okay, so now we're going to start off with a patient that presented to us, and just want you to kind of pay attention to some of the things you see on the patient. Sometimes the notes are a little bit redundant. That's okay. A lot of different people see our patients, and that's really great because different folks say different things, and then they all come together, have a nice conference together, and really come up with a really fantastic and excellent plan. So this patient is significant. He's been with us before. He had a TERP on 2/2022, and now he's coming to us at the end of the month of March in 2022. The ECC provider note says this patient was transferred to us. He has hematuria, and he was transferred from somewhere else for his hematuria and for a significant change in his level of consciousness. Now, he's a 62-year-old man. He has a history of bladder cancer, orchiectomy, and a TERB-T on 3/7/22. He presents as a transfer from another place for altered mental status and hematuria, and per his records, and that per that hospital records, he was quite altered, and they were seeing that he had Graves' hematuria. But when we got him, the main reason they sent him to us was because on his chemistry, he all of a sudden had a creatinine of 6, a BUN of 162, platelets of 9, oh my God, and a potassium of 5.6. So he got transferred to us because they didn't have urologists. It was really a lower level institution, kind of a skilled nursing facility. And he comes to us because he needs to have a urologist. He's only oriented to himself. He continues to be quite altered in terms of his understanding of any of his situations. So here is his basic history. So you'll see here in hematuria in 2019 and all the rest of these in 2022. So sepsis secondary to a UTI, chronic hep C without hepatic coma, history of urethral strictures, liver fibrosis, and here on 3/26/2022, this is his new diagnosis, renal failure. Okay, so we don't know for sure. We think he's probably got HRS, right? Because he meets that criteria, right? He does have some shock. He has sepsis. He has other problems, but he has liver fibrosis, chronic hep C, not been in hepatic coma. And we're thinking that this patient may have HRS because he now has renal failure. Okay, so, So just some of the things that we didn't review already in notes. O2 sat was in the 80s on room air. They put him on 2 liters of oxygen, and that improved. We don't have a level. Nobody documented to what it improved to, but he did improve. Very cachectic, really, really thin. He's tender over a suprapubic region, and he has very dark, very small amounts of urine in the Foley. Prior visit, March 19, 2022. So remember, this is a month earlier, or a week earlier, I guess. He came with hematuria, evaluated by urology, had ultrasound. They cleared him for discharge, and they asked him to come back for outpatient follow-up. Okay, so that's March 19th, 2022, right? First time he had hematuria was 2019. Now in 2022, he has hematuria, and it is actually just 6 days later. I'm sorry, I said skilled nursing facility, but I didn't mean that. It was like an outpatient medical center. They're the ones who sent him back to us. But what was really important, March 19th, 2022, we're now at 3/25/2022, 6 days later, March 19th, his BUN was 0.8, his creatinine was 0.8, his BUN was 17, and his platelets were 299. Okay. Now he comes, when he goes to this clinic, his BUN is 162 and his creatinine is 6.16. Okay, in 1 week. So he has ascites, he has liver fibrosis, he has chronic hepatitis C, and he has a very short time with a very acute process going from being normally renal function to very severe, profound abnormal kidney function. This is type 1 HRS. So here at Grady, of course, we want to look at every possible problem. So lots of differential diagnosis that included uremia, renal failure, AKI, intracranial bleed, electrolyte abnormalities, toxic metabolic encephalopathy, blah, 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 blah. No discussion at this point of HRS, mostly because the focus is really on his kidney right now. And a lot of times, because this is such a discrete finding, that you may not have folks that have that much experience with HRS and the recognition of that pathology that occurs with that ascites process. It's all good. They do beautiful labs. You can see they did every lab possible: lactic acid, UA, blood cultures, sternum monzocin. He gets some fluids. He gets a CT of his head, chest, abdomen, and pelvis. And calcium gluconate was given while the labs are pending because of the concern for his hyperkalemia. Okay, so here's all the same thing. Now we get a few more things in his information. Okay, so, right, we know that he's got this urethral stricture. He's seen at Grady 319 because he had a scrotal wound, discharged without any problem. And he transfers from this other facility with his altered mental status. And here's his creatinine, BUN, platelets, and potassium. Of course, that's very concerning. Okay, this was a patient was transferred for urology consult, but urology actually didn't know that he was coming. And for me, probably I'm not as worried about urology as I am about nephrology, but that's okay. Urology comes, they take a look at him. They want to see, does he have an obstruction? Because he does actually have, on visualization, when they do the ultrasound, they do see that he has high dual hydronephrosis. So he has a lot of volume overload in the kidney and in the tubules, okay? So they put in a 20 French catheter in the OR under direct visualization, but they can't really drain anything. It's just dark brown fluid. And they say, well, we think he's septic and we can't actually irrigate with sterile water. So we had to place that other catheter. So now let's just take a look at him on 326 at 1512. Sodium is 142, potassium is 6.2. His total serum CO2 is 14, which tells you right away that he is acidotic. Now, remember, when bicarb goes down, metabolic acid is up. He's absolutely acidotic, no question. But usually we expect to see a gap, a wide anion gap greater than 20, except in patients who have received aggressive diuretics. That then will mask their severe metabolic acidosis. So the thing I want you to remember is his total serum CO2 is down. His gap is high, but it's not profoundly wide, but you should never trust this gap. You should never trust a gap that's low when your patient has received aggressive diuretics. So that causes an alkalinization and it limits how profound their gap elevates. Then you see his glucose is 99. For me, that's really worrisome. I think that that's, just remember that both your liver and your kidney are producers of glucose from non-glucose products. That's called gluconeogenesis. You have liver failure. You also now have renal failure. So a glucose level of 99 often will get explained because the patient's cachectic, he's not really eating and he's not doing very well, but you'll see just 6 hours later, his glucose drops to 77. So I would probably always think about asking my docs if we could do some glucose supplementation and try to get that glucose level up to about 140. Our normal standards here, 140 to 180. I want you up around 140. Okay. And you can, of course, see the BUN is very high, creatinine is very high, and GFR. So really, really important to remember that normal GFR is 120. GFR less than 80 is really severe and indicates kind of an end stage of renal dysfunction. And his serum is very, very concentrated. Okay. Now his sodium is low, but his serum is very concentrated. And you can see his albumin is low, and no surprise there. And his total serum proteins are low. No surprise there again, with ascites and liver dysfunction, etc. Bilirubin is high, direct bilirubin is high, AST, ALT, and ALK phosphate all high. No surprise there either. And lactic acid is quite high. Now I want to just take a point here just to remind everybody, as much as you love lactic acid is not an indicator of sepsis. You have two types of lactic acid, type A, which is usually from ischemia to the cells, or type B, which is more affected by liver disease and kidney disease. Now, our patient is acidotic, so he probably has some degree of lactic acid elevation that has to do with his poor perfusion. But he also has elevated lactic acid from his liver dysfunction. So it's just really important to remember that the liver is responsible for the clearance and conjugation of lactate. Lactate enters into the liver system, goes through a wide variety of metabolic chains, and actually becomes bicarb, or the source of bicarb. So you got to have liver function to make bicarb and to take lactic acid and correlate that. So really important to look at that. He always has an elevated lactate level when we see him. So right now, what's his kidney issue and what type of renal dysfunction do you think began this issue? Well, right now, we are still thinking that the probability is that this patient has got hepatorenal syndrome and that the renal dysfunction that started this all off was hypoperfusion to the kidney. Okay, so now you look at the consult. This is the urologist, right? We're consulted from the ED for this patient who has limited urine output via Foley, is severely confused, BUN 188, creatinine 4.6, K 5.7. That's a little different than what we saw. This is actually now on this day, although I'm not sure where they got those other numbers. And lactic acid 7.1. So they decided that they need to rule out for obstructive uropathy. And so what they've decided, they've called nephro. Nephro says we're going to do emergency renal replacement therapy. Patients start on CRT and sent to the ICU. So that was the nephrologist, I'm sorry. The urology team is also consulted. They changed the patient's fully irrigated and noted a very small amount of urine output. And the CT scans beautiful, severe hydronephrosis bilaterally with renal infarcts. So his kidney is already infarcted, and he starts emergently on CRT. So he's now admitted to MICU, to the MICU team, but there's not any beds in the MICU. So he remains in the ECC, in the transitional critical care unit, getting really great care, but we can't start his renal replacement therapy there. The only thing they can do in the ECC is hemodialysis. So now the APP in the MICU says this patient's got hypovolemia, hypotension, might have sepsis, has pre-existing renal, hepatic, or cardiac dysfunction, doesn't have diabetes mellitus, and doesn't really have any exposure to nephrotoxins. So she's looking at all the causes for what's occurring for this patient. Okay. Now I want to make sure we appreciate AKI versus ARF. ARF is acute renal failure. AKI is an acute injury that happens really, really, really quickly. So when we talk about hepatorenal syndrome, usually we're talking about AKI because, remember, especially if it's type 1 HRS is an abrupt change in serum creatinine and urine output, and it's classified by the Rifle criteria. That's the criteria that looks at renal risk, injury, failure, loss, and end stage. And it basically just tells us about where our patient is in the positioning. More acute renal failure is typically a slower process that actually gives you a very significant electrolyte imbalancing, and actually involves a whole other constellation of systems. So really not a tremendous difference between AKI and ARF, except that with AKI, you have better opportunity to resuscitate your patient and to prevent them from going to ARF. So when we talk about rightful criteria, this is injury. I is for injury. That's like renal ischemia, and then you have renal failure. So renal ischemia to a renal infarct, that's renal failure. So they are part of the same continuum, but what our goal is to try to protect our patients from going further and exacerbating all of their other problems. Okay, now we look at our patient here. He's got hyperkalemia, he's got metabolic acidosis, he has uremic symptoms, and his change in level of consciousness may be just a bit too late for him. By the time we got him, he was already in acute renal failure. It's always important to remember all the different causes for acute kidney dysfunction, pre, intra, and post. This is pre-renal failure. Remember, before the kidney, affecting the volume that goes into the kidney, affecting the pressure that maintains the volume in the kidney. Intrarenal is actually a disruption of the glomerular membrane, or disruption of the tubular membranes, and postrenal is obstruction. And there's a lot of overlap between those three. Okay, so I'm going to give you another patient. This is this is our same patient, just a little bit more information, right? So this is now our nephrology note. The imaging shows that bilateral hydronephrosis, hematoma, and a lot of debris in the bladder, and the bladder wall is thickened. And it's mildly to moderately distended, and there are renal infarcts bilaterally. So again, he's altered, cachectic, malnourished. He receives 2 liters fluid by nephrology. Fantastic. And they say, okay, it's going to take some time. We think there is some obstruction, but he's got to have renal replacement therapy. Because his BUN is 186, we do not believe he's a candidate for hemodialysis, and there's a major reason, and that is concern for dialysis disequilibrium. So ICU team plays a merchant fast cath. They're going to start CRT as soon as the patient can get a bed in the medical ICU. Okay, all discussed, orders placed, everything is gorgeous. And you might say, well, you're down in the ER, don't have a bed in the ICU, and the only thing they can do in the ER is hemodialysis. But there's a lot of concern for dialysis disequilibrium syndrome. So I want to remind you of what dialysis disequilibrium syndrome is, because I think that's a really critical thing for us to remember. Dialysis disequilibrium syndrome often will occur in patients following dialysis. Most often occurs with their first hemodialysis treatment. Well, remember, this patient's never had dialysis, right? This is an acute exacerbation of kidney dysfunction. We believe it's HRS, but the first hemodialysis treatment can actually cause dialysis disequilibrium syndrome. And what's really important is it just causes a profound fluid shift. And you can see this is the brain of somebody in dialysis disequilibrium syndrome, how you've lost the markings, how you've lost that separation of space. You have profound cerebral edema. The ventricles are compressed. And when patients in hospital get their first dialysis treatment in the hospital, they often get a stroke call, because what occurs with dialysis disequilibrium syndrome, because of the fluid shift and the ion shift, is that the patient actually loses depolarization. So they oftentimes will have bilateral plegia. Now, lots of times that can resolve, especially if you give them potassium and sodium support by IV after their dialysis. And if you do that quickly, you can get resolution of symptoms. But frequently, there's a stroke alert called on somebody who has just had their first treatment. And it isn't always just the first treatment. So what happens is that, of course, the brain water shifts, the acute changes in the pH as we are dialyzing them, because we're doing that aggressively. So they go from being acidotic to being normal or even mildly alkalotic. That's going to change the blood flow dynamics of the brain. and it promotes this cerebral edema. So the worst I've ever seen was a person who had seizures and then postdictally was unable to move arms and legs. And actually, that actually happened on a step down area here at Grady. And they called a stroke alert. The neuro team came. I happened to be in the hospital. It was like 9:30 at night. And I just came up to see what was going on. They said, well, stroke. Neuro said it wasn't a stroke. And I said, well, did your patient just get dialyzed? They said, yes. Oh my God. This is like the first time I ever saw a really severe case of dialysis disequilibrium. So this was why they did not want to do hemodialysis. Even though the patient was relatively stable, his BUN was so high, they were concerned for dialysis disequilibrium. Typically, you don't see that in somebody whose BUN is less than 60, but when it's significantly higher, you see such profound altering fluid shifts in these individuals. So what do you do if this happens? You got to stop dialysis. You got to do blood work. You've got to do replacement for glucose, calcium, sodium, and potassium. And you might need to do seizure prophylaxis or treat seizures as they occur. And one of the things that's really important and why we should be talking with the nurses who come to our bedsides to do hemodialysis is to say, here's where his BUN is. Here's what our concerns are, because they can make decisions about doing a short session at a low flow. Okay. Now, remember, when we do CRT, we're using very low flow. We're doing 200 mLs per minute. But when you're doing dialysis, you're doing 400 to 1,000 mLs per minute. It's really fast flow, and it's really aggressive clearance because they have a very large surface dialyzer. In CRT, your filter is much smaller. And so you're using smaller surface area. You're doing a slower flow. Even though you're doing a longer session, you can achieve some similar results over 48 hours that you could achieve in 3 hours doing HD. The problem is that when I do it in 3 hours with HD, I'm going to promote profound electrolyte abnormalities, and I can promote profound cerebral edema. So that was their concern with this patient. The other thing that's really important for us to remember, and this is something that worried me a lot about this patient, was that he was not able to sustain his glucose. Now, risk for hypoglycemia is higher with chronic kidney disease and end-stage renal disease, but it's also much higher when you have patients who have a hepatorenal dysfunction. It is very, very common. If you have liver dysfunction, you can't clear insulin. Your kidney cannot clear insulin if you have renal dysfunction. So you are no longer clearing insulin. You're not excreting it. So insulin goes up. 20% of gluconeogenesis occurs in the kidney and another 20% in the liver, but now you have hepatorenal dysfunction, so you can't make so much glucose, or glucose from non-glucose products, so your patient's glucose goes down. So their circulating insulin is up and their glucose is down, and they have very significant risks for hypoglycemia. So one of the things I just like to remind you, that's something you really got to talk about with your dialysis nurse, need to be really aware. If you're doing CRT, if you're doing it here at Grady, we use a 4K bath. That's the major bath that we use. And in the 4K bath, it has phosphorus, and that replaced the glucose. So the bath contains 0 glucose. So you put somebody who's got a glucose of 77 on a 0K dialysis bath, they're going to become hypoglycemic, and that hypoglycemia is going to kill them. So these are all things we have to think about. So we're going to remind ourselves that with this patient, we believe he has hepatorenal syndrome. Remember, they have systemic systemic vasodilation and renal vasoconstriction. They have low renal blood flow and low GFR. They retain sodium and they retain water, more water than sodium. So sodium typically stays relatively normal, maybe even a little bit low. By chemistry, they look like they have prerenal failure. Prerenal failure means that your sodium is less than 10%, your FeNA is less than 1%, you're not making much urine, but you don't have proteins in your urine. So this is really important because this patient actually has HRS. Okay, so this is that new criteria: liver disease with ascites, serum creatinine greater than 1.5, no improvement after 2 days off diuretics, getting volume with albumin at 1 gram per kilogram of body weight per day up to a max of 100 grams per day. Albumin is what is given to these patients because they have so much protein loss, okay? Now, if they have a bacterial infection, they don't have shock, this could also be HRS, but in general, what we say is you're going to rule out bacterial infection before you diagnose HRS. Okay, no current or recent treatment with nephrotoxic agents, as mentioned before, okay? And they don't have internal or parenchymal disease because they don't have proteins greater than 500. So remember, parenchymal disease, you see protein higher than 500. You also can see microhematuria and abnormal renal ultrasounds. Remember, our patient had protein less than 500, although he did have hematuria. So this is his urinalysis. Urine is red, very cloudy, normal specific gravity, basic quantity or quantification of the urine, normal, has protein, doesn't have glucose, doesn't have ketones, has a bit of bili, okay? Negative urobilinogen, which is the byproduct there, okay? Hemoglobin is elevated, but that's really hard to tell the difference between that and myoglobin. Nitrates, normal. Nitrites are normal. White count is a little bit elevated. Red cells are a little bit elevated, okay? But what he really looks like is that he has pre-renal failure, okay? Very, very, very important. All right, so then we go forward. He gets started in CRT, receives D10 for his hypoglycemia, 62-year-old man, blah, 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 all the things that we know. He gets started on D10 for his hypoglycemia. He gets emergent CRT, and his blood cultures are positive. So he does have infection. Okay. Overnight, the attending notes he got worse. He required vasopressors. He got an art line of CVP. He's on Levophed and vasopressin. Stress dose steroids were added. He's at net even, meaning what went in came out. CRT for refractory hypotension. Intubated for hypoxic respiratory failure and airway protection. So he gets much, much, much worse. Okay. And they meet with the patient's 4 adult children. They explain that his condition has continued to decline despite maximum support. Family says they don't want the patient to experience suffering, and they are all in agreement that they're going to put the patient into a DNR status. Okay, and that's just the time he spent there. Okay, so if we look at our patient, we'll see his oxygenation. This was really poor. I don't know what happened right here, but he got intubated, and you can see this is really where he had hypoxic failure. He got intubated, and he's looking pretty good. His CO2s are low. His base is relatively normal, except right here on 327. Hemoglobin's okay. He's not looking terrible, except for that one period where he had significant and profound hypoxia. And there's his chest X-ray. And here's his chemistry. And you can see potassium came down, but it went back up, right? CO2 content went up, but his gap is still relatively normal, which was always very amazing to me. And his glucose, of course, he's getting D10, has gone up. But you can see almost all of his labs are significantly and profoundly abnormal. His lactate never returns to normal. It never recovers. He has liver failure as well as renal failure. So he has the combined hepatorenal syndrome. And this I would classify as a type 1 hepatorenal syndrome. Okay. All right. 330 gets worse. Right. 331 overnight. They weaned him off the vasopressors for 24 hours. Tried to wean him from the ventilator, but he failed. Spontaneous breathing trial. Had very significant hypertension, tachypnea. He did get a unit of packed cells because his hemoglobin dropped. And he passed away on 3/31 that night, that evening. So very, very important. If we look back at this and say, if we thought that he had hepatorenal syndrome, I don't really think that was a discussion. They probably didn't think he had it, I'm sure. I didn't see it discussed anywhere, and much greater minds than mine were taking care of this patient. But I would tell you that there are some things that we could consider, that we could try on a patient like this when we have concern for hepatorenal dysfunction. Now, I'm just going to give you another case. It's very, very short. 65-year-old woman, history of alcoholic cirrhosis, comes to ED from nursing home for altered mental status. They said that she was recently admitted to an outside hospital for hematemesis and confusion, but no endoscopy has been documented. The staff says that she just progressively got more confused, progressive decrease in urine output, found laying awake in the bed, confused but speaking. But when she gets to the ED, she's jaundiced with scleral icterus and only opening her eyes, painful stimulus without purposeful movement. Her vital signs are 89/52 with an MAP of around 61. Her heart rate's 93, respiratory rate's 21, SAT's 99% on room air, and core temp 35.1, freezing cold. She looks infected. She looks like she's got liver failure, and she looks like she has renal failure. And indeed, she followed a very similar course as our patient did. She did not survive either. So in summary, hepatorenal syndrome is a functional and reversible form of renal failure in patients with advanced chronic liver disease, but you have to recognize it because you're going to treat it quite differently than you treat standard renal disease. These interactions between portal and systemic hemodynamics cause actually a very intense renal vasoconstriction with a very significant portal and systemic dilation. And you may have no precipitating factors, but there are some known triggers like infection and other conditions that might occur. The worst prognosis of all the complications of cirrhosis is renal failure. And terlipressin, which is the newer form of vasopressin, we have it on formulary here. Terlipressin is the drug of choice in treatment for enhancing better blood flow, promoting the systemic and portal vasoconstriction, which then allows for more renal vasodilation. Liver transplantation, of course, is the definitive cure for patients. CRT is necessary, and liver dialysis may be very helpful. So if your institution, your area is not doing liver dialysis, certainly here in Atlanta, we can transport patients to Emory, where they do actually use what's called MARS. It's a liver dialysis therapeutic intervention. We have let me say it this way. We have the primary equipment to do MARS, but we do not have a liver specialist. This is not a nephrologist. This is a liver specialist who will do liver dialysis. So again, just want to remind you, the very most important thing is the first therapeutic intervention is to put the patient on vasopressors, because the body's own compensatory mechanisms are restricting renal perfusion, profound renal vasoconstriction, because you have a profound portal hypotension. So using systemic vasoconstrictor will enhance portal constriction, and that in turn will promote renal vasodilation. Terlipressin is the drug of choice, not always so readily available. Everybody doesn't have it, but you can use octreotide plus midodrine. And everybody has midodrine. Everybody talks about they're giving midodrine to wean patients off of norepinephrine. Midodrine plus octreotide in these patients can be beneficial, and you can also use norepinephrine. But part of early management should be administration of albumin supplementation. So what we have to think about is we have a communication with our colleagues. Because of liver disease, because of cirrhosis, is it possible, or because of portal hypertension, is it possible that the patient is exhibiting HRS? If the patient is exhibiting HRS and they've been getting volume or they've been getting diuretics and they're not responding, we're now going to shift as quickly as possible, actually, to vasoconstriction, which then will promote some portal constriction and promote renal vasodilation. Because the renal constriction is a direct response to the systemic vasodilation. So now we're going to cause some systemic vasoconstriction and promote some renal dilation. Terlipressin is the drug of choice. You should know whether or not your formulary carries it our formulary does carry it. Okay, it can only be given IV here in the United States. Okay. IV albumin supplementation should be initiated as part of early management. Now, that is unusual for me to say. In general, I don't really support albumin supplementation because it leaks across the leaky barrier. But in this case, what you're actually trying to do at the same time that you're promoting this vasodilation, vasoconstriction balance is you're trying to improve the circulating blood flow, even for short periods of time. If an ascites sample is drawn, and it should be, you should always then start on third generation cephalosporin, and then think about CRT, a TIPS procedure, liver replacement with MARS, or liver transplantation. It's a high complication of cirrhosis, and once it occurs, it's a 1 to 7 month prognosis. It typically is related, again, what we have is portal. We actually see release of excessive vasodilators that triggers a compensatory response to reduce kidney perfusion and reduce kidney pressure. It should always be considered, always, in patients with cirrhosis and ascites plus AKI that is refractory to volume resuscitation. So not because our physicians aren't thinking about it or aren't worried about it, they've just got so much else that they've got to think about. Our role is to say, look, patient's got cirrhosis, ascites, and acute kidney injury. Is it possible this is HRS? And it is always a diagnosis of exclusion, which is really, really important for us to remember, a diagnosis of exclusion. So it's aided by ultrasound, you look at volume status, you look at obstructive nephropathy, and it can assist you with paracentesis. Very, very important to remember. Vasopressors and albumin. So what can we learn? Always consider obstruction with a catheter. Scan your patient immediately when they have decreased urine output. Always consider liver failure for anyone who has alcoholic abuse, and always consider hepatorenal syndrome, which again will be treated with particular vasopressor. Terlipressin if you can, norepinephrine if you don't have terlipressin, or you could use oral agents, but you may not be able to give this patient anything orally, so that may be an issue. But very, very important, control as quickly as possible their hypoglycemia, and make sure you're telling the story with your charting. Make sure you are discussing your concern, possible HRS, discussed with team rules out, fantastic. Looks like everybody knows what they're doing, and we're all looking out for the patient. So these are all good things for us to do, for us to recognize, for us to treat. Thank you very much. I'm going to stop recording now, but I'm certainly available if there are any questions. Thank you so much for attending today's Tuesday topic.